go ahead and look for the poll that should be popping up there, asking you whether you have been diagnosed with COVID, or if you have put off clinical visits or imaging for CCM because of COVID concerns. In other words, have you delayed going to see your physician, your care provider, or getting an MRI? And people are starting to respond. So we have...
Connie, how many are signed on?
Right now we have 47 people signed on, 48, and it's going to keep going up for a little while.
Of course.
Yeah. So the poll is going to be open now for the next 30, I don't know. I'm going to leave it open for another.
Yeah, leave it open till more people
36.
join in.
Yeah. So welcome. This webinar is CCM and COVID-19, or CCM updates in the age of COVID-19. And we have joining us today Dr. Issam Awad, who all of you, I believe, already know, but by way of introduction, I should have this memorized by now, but he is the chair of the Angioma Alliance Scientific Advisory Board and has been since inception. He is the University of Chicago's John Harper Seeley Professor of Surgery. He leads the neurovascular surgery program there and is the director of our CCM Center of Excellence at the University of Chicago. And also joining us are the nurse coordinator for our CCM Center, Christina Piedad, and the research coordinator. Is that the title?
Yeah, the research manager.
Research manager, Agnieszka Stadnik. And so without further ado, I'm going to hand it over to you.
Thank you. So the poll is open in terms of diagnosis of COVID-19, and maybe in a little bit we can find the answer, and also the second question. So I encourage everybody to vote. Good evening for everybody who is in our time zones, and anyone international, hello. So I think I want to give credit to Kelly Fleming, my partner on the scientific advisory board, with whom we've been working on the COVID CCM registry, which I'll tell you more about. She deferred tonight because she thought a lot of the questions are going to be related to actual care and the virus and so forth. So I'm happy to try to do the best I can in answering some of the very cogent and important questions. I had a taste a little bit of some of those questions that Connie shared with me earlier today. So I know kind of what's on your mind. And I've asked Agnieszka and Christina to join me, and they're still at work, and I feel so indebted to them because it's been a long day enrolling patients and following patients and so forth. And I thank them for staying on through the stretch. So I think what I want to do first is give you a few slides that summarize our approach to neurovascular care as we've struggled through the COVID era. Then after that, maybe we will take the answer to the poll, and then I will give you a few more slides about the COVID CCM registry, and then we'll open it up for questions. So does that seem like a reasonable thing?
Yes, it does. And I just want to encourage folks to use the Q&A when they're trying to ask questions. It's easier than if we're trying to look for it in the chat.
All right. Everybody sees my screen?
Yes, I hope so.
Okay. So basically, there has a lot of concern about how this virus on the left-hand side will affect all the blood vessels, the many miles of them that are in our brain, and particularly if those blood vessels are brittle and they have COVID, and they have cavernoma. So therefore, it is very important to understand where we are at the cross-section of these two problems many of you are living now. So I want to talk a little bit about how we went about prioritization of care adapting to the pandemic, and the precautions we are taking during the pandemic. So, see how do I advance? So, does that go?
It
Either goes all together or doesn't go. Okay, so I have no disclosures or conflicts of interest, and the objectives here is to follow with you the guiding operational and ethical principles that we adopted very early on in this crisis, how we have handled neurovascular surgery emergencies, how we have handled medically necessary time-sensitive procedures and what we mean by that, and how we have handled general neurovascular care, clinical trials, and other human subject research. And I share with you some of the emerging neurovascular hypotheses from the COVID-19 observations and experience. So, the guiding operational and ethical principles, first and foremost, were to protect the healthcare team and non-infected patients from COVID-19 infection. So this is the most important and first thing on our mind every day through this pandemic. First of all, we don't want any martyrs in the course of healthcare delivery. And we don't want any non-infected patients to suffer COVID-19 infection. So this involves the use of all the protective devices, the adaptations in emergency and procedure area, negative pressure ventilations in our hospitals, the implementation of televisits and telerounds, limiting team members' exposure in every way. So if there is a patient who is infected and must be seen, if we can see the patient from outside, it's better than seeing them at the bedside. We use a lot of electronic and imaging and recording and video to do that, and therefore do what we call risk mitigation. Separation of COVID clinics and inpatient units from the general care, physical distancing and decontamination every minute of the day. So these are the first principles. The second is, which is very, very important, is to continue open access to all stroke patients through hospital messaging, that we are open. We have not turned into a COVID sanitarium, but we are actually open for care. The team outreach, trying to reach our patients, engage people in televisits if appropriate, and making sure that we communicate the availability of safe care areas. And we implement a lot of COVID-19 testing, including testing every single patient who enters the hospital. So not the clinic area, because the clinic area is totally separated from the COVID-19 care area. So anyone who has fever or on the questionnaire at entry has any potential of even remote exposure to COVID-19, then they go to a separate building where there is a separate care team that processes them. So you don't enter our clinic building without having your temperature checked, without answering this simple questionnaire, and then that building is basically COVID-free. The third principle is to guarantee that COVID-19 positive patients also have access to our care. So, the way we deploy the care in the COVID-19 units and ensure that they get neurovascular care by the neurovascular team, even though they are COVID-19 positive. And I will share with you some examples where this has been extremely important. So that's kind of the general operational and ethical principle. Before I go to the next slide, I think there is another important principle that has come up, is that none of us are able to totally avoid the risk of COVID-19, whether we are at the supermarket or in an elevator in the building where we live. or delivery person giving us food or whatever. However, our goal is to mitigate the risk and manage the risk in a way that we keep it absolutely minimal. Of course, we are living with other risks that we mitigate all the time, and we try to live with those risks as well. Every time we get in a car or an airplane, there are risks involved, but we have managed to understand how to minimize those risks, and the same is true with COVID. I want to also get another principle out on the table before I go to the next slide, which is what does the mask do and what does it not do? So you've heard a lot of things that you need these very special space age masks or the very expensive N94 masks in order to filter the virus, and that's actually true. So the cloth mask that we wear and the paper operating room masks, they do not filter the virus from us very effectively. However, they prevent us from coughing the virus into the environment. Therefore, if everyone is wearing those cloth and paper masks, they also are prevented from coughing their virus out into the environment. So if you're out there, even though your mask doesn't take away the virus, if everyone else is wearing a mask, then no one is coughing the virus out into the environment. And this is why you mitigate the risk. Of course, if everyone can have the $1 million equipment all day long, that would be better, but that's gonna be costly in other ways. So let me go to the next slide. So the neurovascular surgery emergencies continued. So no compromise in standards of care per levels of evidence. So anytime a patient had a bleed in their brain, had an aneurysm, etc., we took care of them. We assumed that every patient could be COVID-19 positive, and therefore we tested everybody. So if the procedure had to be done emergently before the test result came back, we took all the precautions as if the patient was positive, so that if the test came back positive, nobody regretted anything and nobody had to do any additional quarantining or anything. The premise that all healthcare workers and family members could be asymptomatic carriers and could contract the disease. Therefore, we limited the visitors that come with patients to the hospital unless those people could also be tested. So with those precautions, a huge amount of risk mitigation was introduced. And although I know that there were some healthcare workers that contracted COVID in New York and in Italy, and in other places where the healthcare system was overcome by COVID early on, at our institution, and to my knowledge, at all other healthcare institutions in Chicago, despite all the problems that happened with the numbers that we had to deal with, we are not aware of anybody that caught COVID-19 under our watch in our system. So this is a very, very reassuring thing to us, and we cannot chest beat about it because it could happen tomorrow, but the risk was lowered substantially. The concept of medically necessary time-sensitive procedure was introduced to try to fight the idea that we're going to shut down the hospitals and do nothing but COVID. So basically, we prioritize the cases that the risk of waiting is greater than the risk of doing them. And we added to the consent. We tell everybody, you're coming in the middle of the pandemic. There are risks. We didn't know at the time how big they are. Now we can be much more certain that the risks are very low. But we would end up doing the procedure. So we did cavernous angiomas that bled like the one that you see over here. It bled in the middle of the pandemic, and we ended up dealing with it, and the patient is doing fantastic. Many people traveled despite the pandemic, and they stayed in local facilities with very good precautions. And then we were able to either reassure them about their problem or do the right care for them. So the centers of excellence had to actually do a little bit more work to kind of make sure everybody can live within these guidelines. The general neurovascular care, clinical trials, and other human subject research. So we do something that my team is very good at, which we call clinic reviews, meaning if you're scheduled to see me in 3 weeks, it's not automatic. I review your case a few days before the clinic with Christina and with the rest of the team. And at that time, we reassess if the imaging and the visit are necessary. We discuss whether the visit is better in person or by Zoom, whether the imaging is needed and therefore would be done in person. We will individualize this, and we've rescheduled a lot of cases based on that. Physical distancing is part of our clinic world, as you see here, even though we had to move clinics and then return to our clinic. So we were living in a crisis environment, but despite that, we maintained significantly our physical distancing, minimize the personnel that is involved, and applying decontamination principles. Clinical research, initially during the shutdown of anything but medically sensitive visits and interventions, we maintained clinical trial visits as long as the patient was receiving an intervention, and this was allowed by our university. So the clinical trial of atorvastatin continued without any mandated interruption. Critical sample collections, so if we are collecting blood sample for a trial, or we are removing a specimen in the course of surgery, as long as the patient is receiving that clinical care, critical sample collection was allowed. Of course, we didn't process it. We froze the sample because we didn't have personnel in the lab, but now the personnel has returned to the lab, so they're catching up with processing all the specimens. We minimize the personnel for the research tasks. There are a number of people that are in the lab at any one time, and otherwise we would reschedule if the patient does not meet those criteria. Follow-up benefit with proper precautions is greater than the risk of COVID-19. There is no question about that. Today, for example, we had a patient who came for a scheduled follow-up. He could have said, I'm anxious and I don't want to come. He didn't report any symptoms. Then we looked at his MRI, and the more we talked to him, we realized that he was actually just had another symptomatic hemorrhage. And this patient would have had no idea because he was talking himself out of the symptoms. And unless we did the MRI and the follow-up visit that was planned, we would not have known that he rebled. So there are many, many such examples. And this person is a physician. So that just tells you that we can't be too smart. So there are many such examples, and I would be divulging HIPAA rules, and Agnieszka would kill me if I tell you more, but that's kind of what you have to take my word on that. So the clinical trial enrollments continued. You see the dots here. Even during the time of the crisis, we flattened the curve because our expectations was that we will not be enrolling, but in fact, we continued to enroll. Some other sites, you know, like UCSF totally shut down, and it's still shut down. But Mayo, for example, and BNI and others kicked back up into gear, and we continue to enroll about 10 to 15% among screened cases, and this hasn't really changed during the pandemic. So the trial readiness as well as the atorvastatin trial are continuing. The challenge we are having is with some of the year one follow-up visits that are scheduled, and where individuals who may need to travel for a visit to their center of excellence are having second thoughts whether they should put off the follow-up. So we are engaging them, and we're trying to be as flexible with those schedules without compromising the aim of the research. Luckily, we built into all of those studies sufficient wiggle room with missing data, so that we will be able to answer the specific aims. But I am committed to talk to everyone and explain to them the rationale that they are actually better off having their lesion looked at, especially if they are cash patients, than to kind of forget about it and think that it is all okay. So the last slide in this set is I want to basically tell you that there has been a lot of new knowledge about the excessive clotting that happens with COVID-19 infections. People who contract the virus very often get these abnormal blood clotting values. It is not necessarily the case that it is in people who are very, very ill. So it can happen even in people who are not so ill, and then they can develop strokes or heart attacks from the excessive clotting as the main manifestation of their COVID disease. It is still unclear whether we should treat this at one point, at what level of D-dimer calls for treatment. There is a lot of research going on. And people are receiving blood thinners very often for these abnormal values. There is otherwise not much evidence of excessive bleeding with COVID-19. So in general, there is more excessive clotting, unless, of course, they put you on blood thinner, or you have multi-system failure in the end stage of the disease. But that's not really related to COVID, because everybody with multi-system failure starts getting bleeding problems. So if your heart and lung and liver are all failing, you may have bleeding problems, but otherwise, COVID itself doesn't seem to cause bleeding. This issue of endothelial viral invasion has been shown. There is no question that in cases that have received autopsies, that has been found. The correlation with symptoms is not so clear. It was often found incidentally at autopsy. The concept of endarteritis and vasculitis is there, and it's theorized, but the cases where it has been proven clinically are extremely uncommon, and they continue to trickle as case reports, not as an epidemic. Even that syndrome that happened in children, so the Kawasaki toxic shock syndrome, unsure if it is the virus or the inflammatory storm, and although it received a great deal of press, it remains a very, very rare syndrome in young people. Science is a deliberative process. It's not how CNN and Fox News work. Hypothesis generation requires testing and proof. Pseudoscience is very quick, but it is ultimately more costly. And you know, the story of hydroxychloroquine is one of those where people jumped to conclusions, but where the evidence told us otherwise. We will continue to have false starts that we have to back out from. And this is the process that we are living with. So I'm gonna end this part of the presentation and get Connie to give us the results of the poll before I go to the remaining slides, and then we'll go to the Q&A. Do I need to come out of the stop sharing?
It would be good if you did.
I
there
did.
you go. Okay, there. Are we all back? Okay, so the poll results are in. I haven't closed it yet, but what we see right now is that diagnosed with COVID-19, 12% of our current attendees, so 10 of our attendees out of the 84.
Can you ask those 10 how many of them registered in the registry?
I can't ask them specifically, but I
No,
can.
not specifically. You ask, you have 10, so we'll need to know how many registered in the registry.
Yeah, I can't, right. I will find that out after this, but I have in the chat put the link to the registry, www.angioma.org/COVID.
No, I'm not going to get away with that. I wanted people to raise their hands if they have COVID. They said they have COVID and they didn't register in the registry.
And they have not registered.
Yeah.
Okay, hold on. Let me see if we have a hand raise. Do we have a hand raise option? Because I'm trying not to mess with people.
Can we put another question maybe about that?
We can't add questions.
No, we cannot do questions. Okay.
Yeah, sorry, next time. So anyway, if you have been diagnosed with COVID, if you have a positive test, not just if you feel like you had it, or if your doctor says, well, you know, it looks like you had COVID. If you actually had any of the testing types,
yes,
and were diagnosed, please join the registry. And then the other part, the second question was, have you put off clinical visits or imaging? It appears that about 20% of attendees have delayed imaging or clinical visits. And so I hope that you're reassured by what you've heard so far, that probably is not necessary at this point. Does it depend a little bit on where they're being seen?
Of course. I think it will depend on what the activity of COVID is in your region. And the center you are seeing, and you know, I cannot vouch for other hospitals in the country and what they're doing, what they're not doing. So, so that is good. This is a good segue to my other slides. Before that, I want to ask if Agnieszka or Christina have anything else to add to what I said about the care paradigms that we are doing. Christina, Agnieszka?
I don't think I have anything further to add, no. Likewise.
Good? Did I say it the way it's supposed to be?
Yep.
All right. So let me go ahead back and share the screen. And so I'm gonna basically explain to you why I insisted on that question with Connie. So this registry is a registry that was launched by Angioma Alliance, University of Chicago, and Mayo Clinic. It's open to any patient who has had a known cavernous malformation and has had a definite diagnosis of COVID-19. That means a test, not just fever and stay home for 2 weeks and I felt good after that. So we have had to have a test. We'll talk a little bit about the limitations that imposes. But what the goals of the study is to basically tell us if the course of the disease when those two entities are together is any different than we know the course of CCM alone or COVID alone, because that's a very important thing that everybody asks about. So we estimate that about 4,000 CCM patients reached via Angioma Alliance have heard somehow about this registry. Maybe people who are reached by Angioma Alliance just ignored that message or whatever. So there are limitations to this estimate. But on the other hand, we reached out beyond the Angioma Alliance. So we reached out to the rare disease networks. We reached out to patient support groups at other countries, and also to the centers of excellence independent of Angioma Alliance, and encourage them to have patients register. So we do understand that we may count less people if somebody had the COVID and wasn't tested. We understand that tests can be false negative. That's all true. However, we're following the epidemiologic principles so that if we have the two, at least we can be sure that that association is actually correct. So far, we have had 17 persons registered. So if there were 12% of people on the call, if that was true out of the 12% of the 4,000, then there are many, many people with COVID who didn't register. But far more likely, we don't know if those 10 are the same who registered. We don't know if those 10 actually have COVID. Just because they raised their hand doesn't mean they did. So we will, this is why it's important to be in a registry, because we will adjudicate and verify the impression that one may have had COVID, or how big it is, and what the rumor mill is about how many have had it. So of those, 2 were in the UK, 1 was in Australia, and when we looked more into it, only 13 of those 17 were actually eligible, because one of them, they have no longer a CCM. So their CCM was removed years ago and they had COVID. So they didn't count. If you have multiple lesions and you had 1 removed, you still count because you have many other lesions. There were other people who never really had the test, and 1 really never had COVID, but they registered. So this tells us that people will think they have COVID, they'll be eager sometime to register, but they do not. And just like there are people who obviously may have it and they don't register. Of those who registered and are eligible, the other important problem is the follow-up visit. So they register and give us an email and the phone, and then half of them do not answer the call or the email when we reach out to them to fill the questionnaire. The questionnaire takes about 10 minutes on the phone. That's all there is to it. There is really no other proprietary information we ask. And yet about half of those eligible have not answered our phones or repeated emails for the return. So this is the limitation scientifically of a very good and well-intentioned effort. Now, still we're gonna get enough data because we're not gonna let you be. So if there are really 10 of you who had it here, I want all 10 of you to be in the registry. So we know about your case and we know about your situation. So that's my one message. The actual enrolled patients on whom we have data, they are of all ages, as young as 28, as old as 64. They include both sexes. We don't know if the female prevalence is real or if it reflects reporting bias or the desire by women to participate more than men. That will never be known. We had both sporadic as well as familial cases. And most of them had the PCR test, although the antibody test or the rapid blood test, all of those are allowed if you had those tests. All of those patients who reported in the registry did not require hospitalization due to COVID. So they had relatively mild disease that was managed despite a positive test without hospitalization. This is great. There is, of course, a bias. There could be sick people with COVID who died from COVID who have CCM, who nobody bothered to report them, and we'd never know about them. I have some ideas of how to get to those cases through the centers of excellence and through appealing to doctors throughout the country. But for now, we are not aware of such cases that really had had COVID so bad that they were dying from it in the setting of CCM disease.
Dr. Awad, I need to interrupt for a second.
Uh-huh.
Folks, I need to interrupt for just a second. Your slides are not showing for whatever reason to the viewing audience. I'm wondering if you could just stop the share and then share again and see if maybe that will fix the problem.
Okay, I stopped the share.
All right, and then share your screen again and let's see if we can find out if they're showing.
Do you see it?
I do, but I've gotten a number of people have been writing saying that they don't.
I'm really sorry about that.
No, it's not just you. Okay. So I don't know quite what the problem is. Just keep going because there's.
Yeah, we'll keep going. Surely, what I'm saying, nobody knew that I was going to be showing slides anyway. So
Yeah.
So basically, people, only one patient required hospitalization, but it was because of a bleed, not because of the COVID. The COVID was asymptomatic. They had a bleed, and we later found out it was a cavernous angioma. So they didn't know they had a cavernous angioma. So there is one case of a bleed from a previously unknown cavernous angioma, and the patient happened to have COVID, had no other symptoms of COVID. We discovered it because we tested them. And the others who had both COVID and CCM had fever, cough, headache, and other symptoms, but they never really got to the hospital from their COVID or from their CCM. The outcome, all 6 patients had full clinical recovery, including the one with the bleed. So that's what we know so far. Let me just do I think, one last very quick slide about the current progress. So the efforts are ongoing to enhance the registration. So I think, you cannot tell us that you've got the problem and not share some aspect of it anonymously with the world, so we can learn about this disease. We want to appeal to those who registered, who we believe have the problem, to actually respond when we try to contact them on the email and phone, or their power of attorney can respond or can report. So if the person is so sick, someone in their family can do it on their behalf. Reach out to the centers of excellence to summarize data on any cases they are aware of. They can give us that anonymized without breaching any confidentiality, so they can summarize their experience with any COVID that they know of without breaching the confidentiality, and urge their patients otherwise to register if they can. We will continue to scan the literature for any reported cases of CCM bleeds and COVID, and CCM and COVID. We have seen no such reports so far. And until now, we remain unaware of any case where COVID-19 verifiably impacted a known CCM lesion. So we know that the disease can coexist with CCM. We do not know that it has verifiably impacted a known CCM lesion. And we also do not know of cases where COVID-19 course was complicated because the person had the CCM disease. If there are such cases, we do not know about them. We do know a single case of bleeding, as I told you, in a previously unsuspected CCM, and we diagnosed the CCM from the bleed, and the COVID-19 infection was asymptomatic. So that's what I know as of today, and I think as always, I tell it as it is and I share it as it is, and let's go ahead and get to questions. So let me stop sharing so we can see people's faces. It's better, and we'll go from there. So Connie, it's in your hands.
Yeah, so the big question I think everyone that I've been talking with lately has is about their children and going back to school. I know that you are not Solomon, although you are very wise. But would you offer any suggestions for the metrics that people should be looking at to decide whether or not they're children with CCM, the siblings of those kids, or children who are coming into a home, back into a home with a parent who
Yes.
has CCM?
So this will depend, my answer will depend on the status of the disease in your communities and your medical and neurologic condition with CCM. So I think if somebody has an asymptomatic CCM lesion or low burden of disease without any disability or recent bleeds from CCM, probably making the decision the way you would if you didn't have CCM. So that decision, as you know, is not black and white, and the whole world is debating it. But if you're in your community and you didn't have a CCM, you would send your kid to school. There is no reason that you shouldn't send your kid to school if they haven't bled and are not disabled recently from their CCM. It's different, I think, if the person has a heavy disease burden, recent bleed, are dependent in some ways or special needs from a prior brainstem hemorrhage, because the consequences of an infection with the lungs can really be more severe. So we call for those people to take additional precautions. Whether that rises to the level of never ever going outside or managing your risk, that is what I tried to talk about a little bit earlier, of trying to weigh the two.
Okay. And then, as you mentioned, brainstem, I think, does that apply also to people with spinal lesions?
You know, spinal lesions can also vary the gamut of severity and disability and symptoms. So again, if a spinal lesion is not causing any disability or recent bleed, if the symptoms are minimal, like numbness or some tingling and so forth, I have no trouble with that person managing their life as if they didn't have the CCM. I think this is all we can say. But if they are disabled in a wheelchair, etc., like all other people with comorbidity, they should be more careful.
Okay. And then again, there's all of these different questions about specific cases. If somebody, for example, is post-surgical, maybe post-surgical from having had a lesion regrow, so they seem to be more prone to having aggressive lesion growth. Is that put them in a different category? There's also familial versus sporadic. We have, what I heard you saying is basically if you haven't hemorrhaged recently or don't have some other disability that puts you into a high-risk category, then you should pretty much treat yourself.
Do it as, yeah, that doesn't mean forget about COVID. We never said that. It means follow the same precautions as you would if you didn't have CCM. I think this is something we all feel very comfortable telling you.
Okay. And then a question about if you should have COVID and you're done with it, is there any reason that a person with CCM could not donate plasma?
No, there's no reason you could not donate plasma.
Okay, so everybody
go for it and donate plasma.
Donate plasma. All right, so someone else was wondering if there's any evidence that regarding the dose of exposure, so how much COVID you get exposed to in terms of the severity of the illness.
Yeah, so the only thing we know about this is about some of the doctors and nurses in the middle of the early part of the pandemic who seemed to die very quickly from very severe COVID, even though they had no risk factors. Like the big example is the whistleblower in China, you know, who was a relatively young physician with no other health risks. But we don't really know. We don't really know how he died or why he died or whatever. So we don't really know, but I think, you know, more virus is probably worse than less virus. So avoid high burden virus.
And then there were questions about treatments. Mostly, I think the more general question is, if someone contracts COVID and there's the list of possible treatments, remdesivir, dexamethasone, anticoagulation, should our patients be given those treatments sooner than perhaps another patient might in the course of the COVID illness?
No. No, I think they should be treated like any other COVID patient. I think where some specific issues come up, if it's a recent bleed from a cavernous malformation, then the risk of anticoagulation is more significant. So then we have to probably raise the bar about anticoagulation. So I'm going to tell you how I would recommend this be handled. Going forward, anybody with CCM who gets COVID, heaven forbid, ask your COVID doctor to get in touch with your CCM specialist. Don't just fall off the radar. So your CCM doctor, especially at centers of excellence, are trained in knowing whether the risk of anticoagulation exceeds the benefit. So for example, with atrial fibrillation, we tell you you should get the anticoagulant. We never tell somebody with atrial fibrillation, don't get Xarelto because you have a CCM. But what we do is watch their CCM like hawks, and we avoid stronger anticoagulants. And maybe we don't do anticoagulants if you don't really need it. So the threshold for using it may be different. The amount may be different. So I think if they're gonna start you on a blood thinner because of COVID, and you know you have a CCM, just tell them it's a yellow light. It's not a red light. It's a yellow light. Just check with my CCM doctor.
Okay.
And that's good advice, I think.
That is good advice. All right, so then the next question is, there are now trials, phase 3 trials for a couple of vaccines. Would it be okay for CCM patients to participate in the phase 3 trials of these vaccines?
So I know we've been asked these, and Christina has answered them. The answer is yes. There is, we want to test everybody for those vaccines, including CCM patients. I think it will be horrible to exclude CCM patients from those vaccines and then not ever know if those vaccines are good for us. So we've got to be part of the mix and participate. There is no biologic reason why a vaccine should hurt a CCM patient that I know of.
Okay. I'm trying to see if I want to make sure I don't ask the same question twice.
There was one about zinc and hydroxychloroquine. Did you get that?
So, okay, did you want to go for that? The question is, what are your thoughts about hydroxychloroquine with or without zinc?
So hydroxychloroquine, I'm just going to give you the science answer. It's not how I feel. It's not how you feel. It's not how President Trump feels. It's about the science. So the science of hydroxychloroquine, there have been a series of trials that showed that it has no benefit and possibly harm. So there is not a single trial that showed benefit to date. The one trial that claimed that was withdrawn from publication because of faulty data. So we have no data to support hydroxychloroquine in CCM. So I have to give you the answer the way a good doctor and a good scientist would do. Now, zinc is even less evidence. There's nothing that tells us you should take zinc or not take zinc. Only thing I know is that zinc plays a role in the worm in CCM. I don't know what the hell that really means for whether more zinc is good, rusty zinc is better, non-rusty zinc. Nobody knows. So
I think someone, I believe, saw a study that hydroxychloroquine is more effective if it's paired with zinc.
Yeah, but that's nothing to do with CCM.
Nothing to do with CCM, I know.
Right.
But, okay. And
it's not effective under any condition, paired with zinc or not paired with zinc.
Okay.
There has never been a study that showed it to be effective.
Okay, and then we've been asked for a couple of clarifications on past questions. One is when you say recent bleed, how recent is recent? And the other one is if people with brainstem cavernous malformations are at higher risk, is there anybody with a brainstem cavernous malformation? Can you define that a little bit better?
Let me take the first question first. So when you have a bleed, that lesion is inherently unstable for the next 2 to 3 years. That risk decreases over time. So the greatest risk is in the first 2 years after the bleed. That's why we do the trials for cash in those patients. However, that doesn't mean the risk goes away. So I think we would apply the same principle here that if you've had a bleed in the last couple of years, your CCM is potentially still unstable. The closer the bleed to now, the more the instability risk. So the more the lesion doesn't bleed, rebleed, the more stable it is. So time works for you. The longer time, the less this becomes an issue. So there is not a point in time where you say, if I bled within 3 months, then it's an issue. Now for the trials, we say you have to have bled within a year. The rationale for that is because we follow patients for 2 more years. So that includes a period of up to 3 years of instability for testing things in trials. But I think for your care decisions, a lesion that bled in the last couple of years is of concern as opposed to one that didn't bleed in the last couple of years.
Okay, and then
what was the other question?
The other question was, you had mentioned that people with brainstem lesions might need to take more precautions.
Only if they have had a bleed or disability from the brainstem lesion. So the brainstem disability can include breathing problems, swallowing difficulty, aspiration risk, therefore a higher risk if you were to get on a ventilator from COVID. So if you were to get on a ventilator from COVID and you had already a prior problem with breathing, like a tracheostomy or difficulty with breathing from a brainstem lesion, then in that way, that brainstem lesion makes you more vulnerable. But if it's a brainstem lesion just giving you double vision and that's it, I don't think it makes a difference.
Okay. A specific question. I'm a teacher and am doing well overall with CCM in the thalamus. It has not been active for 2 years. Should I ask my school for any accommodations at work, or would I qualify? And then the kicker here is many people are not wearing masks in the building despite the mandate.
Christina, how would you answer this? You get these calls every day.
So the question is?
The question is,
I have a thalamic lesion that hasn't bled in the last 2 years. I'm doing well from it, but do I need some special precautions when I go back to school? Will they give me some special permissions that are different than others because of this, especially when people are not wearing masks around me?
And it's a teacher.
Yeah. So a teacher is worried about going back to school if their school is opening because she has a thalamic lesion that hasn't bled in the last 2 years.
Right. So I think the same thing applies from what you just said. If you haven't had any symptoms and you're doing well, I don't think that there's any increased risk. Of course, if other children or other people aren't wearing masks, that's not something you can control. So it gets a little bit tricky there. But in terms of special precautions different than anyone else, I don't think there would be anything different, right?
Yeah, so I think we're going back to probably a common theme, Connie, that should be probably the theme of this webinar, is that COVID is calling on us to make some decisions about schooling, work on its own terms, and those are legitimate and have to do with risk management, right? Do I wrap myself in a bubble and die, or do I go out and catch COVID? And the truth is somewhere in between, and each one is trying to find that happy medium. CCM shouldn't change that happy medium unless you recently bled or you are having active disability from the CCM.
Okay. So another question, it's a specific thing, but I think it might apply to a lot of our parents. It's a question regarding mask wearing in a younger child with CCM. This is a person whose daughter's CCM exhibits itself with seizures that are facial seizures, trouble with speech. She's concerned that when the child returns to school, that a mask would literally cover the symptoms of a seizure. Do you have any thoughts on how they could?
Yes. So there are people also who just wearing a mask can be harmful to their health, you know, if they have breathing difficulties already and things like that. So I think if, you know, the issue here has to be the mask is not to protect you, it's to protect the others. So it's more important whether the people around your kid are wearing masks. So I think, if there is a problem with the mask, masking a seizure or causing a problem, you could ask for permission in a child at the school for your child not to wear a mask. That's okay as long as everyone else doesn't ask for a permission and no one wears a mask. Then probably that school isn't safe.
Yeah. Okay. And then we're getting closer to the top of the hour. I have a couple of not exactly COVID questions. So this is a person, and I sent this one to you previously because it's kind of long. It's a person who has a spinal cord lesion at the C2 level that bled 5 years ago. They had some minor symptoms last September. The lesion had grown slightly. Now in the last week, they had more severe symptoms, which they thought would probably show up as a hemorrhage, but it turned out that there was no change on their MRI. So they're trying to understand how somebody could have a lot more symptoms without seeing an MRI change, and whether there could have been a microbleed. And the person said there was no contrast used on the.
Yeah, so I think, the contrast probably doesn't make that big a difference in this particular question, but the ability to detect a small, tiny bleed at C2 is not as perfect as it is on the brain, because there is a lot of artifacts and susceptibility artifacts. So I cannot exclude a tiny little bleed causing new symptoms in the spinal cord, because there is actually more lesion than there is spinal cord in that area. And it's kind of, so little stuff can happen that you cannot see reliably on MRI. In the brain, we have other ways like looking at the QSM and seeing if the iron has increased in the lesion. You cannot do that in the spinal cord. So it's a very, very tough way to do it. But at the end of the day, it's simple, because is that bleed actionable? What actionable means is the neurologic deficit and the risk of surgery changed here because of this bleed? Is it making you cross into doing surgery? So a bleed you can't see and doesn't make you paralyzed, just you have a little bit more symptoms, would not generally be called actionable. So we wouldn't take you to a risk of paralysis because of it. But if it was seen significant or caused you a significant functional change, like you can't walk while you could walk before, then that is different, right? So we always use this term actionable, which patients hate because they want to know a tiny little bleed, what happened to me. I'm happy to measure tiny bleeds, but at the end of the day, as a neurosurgeon, I won't act on those.
Okay. And then the follow-on question to that is, someone else asked, if a lesion changes shape or grows, is that the same as a bleed, or is that something different from a bleed?
Yeah, we just recently published, I think the biggest paper on this topic. And in fact, it's the same biology as bleed. So the ones that grow without symptoms are more likely to rebleed, just like the others. They're more likely to be in the brainstem, and they're more likely to have bled before. So lesional instability without symptoms depends more on where the bleeding happened and how your brain is, rather than the biology. So we treat them the same. So if you have an increase, a significant increase, it warrants reconsideration of what to do about your lesion. Often, if you have a single lesion, that means take it out and be happy with it. But if it is deep, inaccessible, high risk of surgery, and multiple lesions, we may want to wait a little bit, and the threshold for removing it might be to wait for symptoms.
Okay. All right. I think those are all of the questions that we can answer in the time frame that we have. I did want to let everybody know that we are running a support group, a Zoom support group, immediately afterwards. I dropped the link into the chat if you want to just copy it, and I can do it one more time if needed. And you can join us. Lindsay will be running the group. If there are enough people and she needs some backup, I'll come in too. But otherwise, do you have some final things you'd like to share?
Yeah, I think I just want to ask if Agnieszka has anything to advise about the registry?
No, just please, if you registered, please respond when we try to get in touch with you. And if you haven't registered, please do so. The more information we have, the better we'll be able to answer all of your questions and have some sort of data to back up what we're saying or what you're asking. So the more info, the quicker we get it, the better. So please.
And
If you know somebody who has had it and they didn't register, talk them into it.
And I got a question today about personal health information protections. Do you have any comments on that? People are worried.
Yeah, so this was approved by the IRB at the University of Chicago. There is minimal questions that are asked about your CCM disease and your COVID. We're not interested in anything else about you, and we're not going to publish any identifiable information nor share any identifiable information with anyone. So your zip code will not be shared with anyone. So we're not talking about these things. What we're talking about is being able to count how many people with cavernoma get worse disease or less disease or vice versa.
Okay.
Is that accurate, Agnieszka?
It is, yeah. As soon as we have your registration, we assign you a random number, and that's what your information is tied to. So
we don't even know your name in the registry. We know a number.
Yeah.
That's kind of where we are. That's how anonymized it is.
Yeah.
All right. Christina, anything else for the patients? Follow-ups? Anything you want to tell people?
I would just say feel free to reach out if you have more questions that you feel weren't answered by Dr. Awad's first presentation about precautions that we're taking, and if you have any second thoughts about whether you should follow up now versus later, anything like that, I think it would really help. And I can easily set up a conversation with you and Dr. Awad personally, if that's what it takes, to explain a little bit better. But I am open to answering any questions about that. So you can.
And we're doing Zoom visits. We obviously cannot do Zoom MRIs, but we can do Zoom visits. All righty. Thank you, everybody.
Thank you. Thank you so much. Okay. Good night, everyone.
Good night. Thank you for organizing this, Connie.
You're welcome.
All our love. Bye-bye.
Bye-bye.